Okay, let's look very quickly at how epidemiologists study things. What do they do with their data? So first of all, where do they get their data? They can get their data from clinical trials. They can get their data from surveys. There are certain diseases that are considered to be notifiable diseases, meaning their risk to the public health is great enough that if anybody shows up at a healthcare facility with one of those diseases, the healthcare facility is required by law to report that incident occurred, and they send a form to the public health department that gets sent up to the CDC. A person's name is not associated with the disease, but the incident has to be reported, right? And so here are some examples of notifiable diseases. HIV or AIDS, measles, gonorrhea, tetanus, typhoid, chlamydia, hepatitis, and then the hemorrhagic E. coli. And I think MRSA has joined the list. Yes, it has. Insurance questionnaires collect health data on people. They can be sources of epidemiological data. Interviews with patients when there's an outbreak of something. Where did you go? What did you eat? What did you do? Those kinds of things. Genomic libraries. You've heard a few times now about how, and you saw in the movie how there's information about the genetic sequences of different pathogens, and we can use those to figure out what caused something, right? So we have that information, and that can help identify the cause of an outbreak. So all of these things are sources of data. And so as I told you when I introduced epidemiology, we're going to use statistics to look for patterns in the data. The first thing that epidemiologists usually do is collect that descriptive data, that descriptive analysis. That is like Dr. Snow knocking on doors, right? It's who is sick, where do they live, how old are they male, are they female? All of that is collecting that descriptive data. It's just that information that helps build a pool of information about a particular disease, right? So, and then you can look at that and you can start looking for patterns. You can say which factors seem to be associated. Is it where they live? Is it how old they are, right? So I have one here where we're looking at a particular disease, and you can see there's a definite age bias, right? So is it something about the person? Is it their gender? Is it their age? Is it their occupation? Is it their personal habits? Like, are they a smoker? That kind of thing. Is it their socioeconomic status? What seems to be the pattern of the disease? And then we can get down to the analysis of this data. Oh, sorry, this is still descriptive. We can look at seasons of the year. We can look at the timing of the disease. Like we saw that one disease looked like a winter disease, and I said it was influenza. We can look at the timing. So here we have a graph showing two different patterns you might see with the disease. In the blue, you see that there's an outbreak, and it seems like everybody gets sick at once and then it goes away. That's called a common source outbreak. Everybody was exposed to something, a bunch of people got sick, and then it was gone. As opposed to a propagated epidemic, people are getting sick and then it's continuing over time, right? This is something that is probably being spread between the people. That's what's allowing it to persist in the population instead of just that one exposure causing the disease. It's like exposure and spread, right? So that's a propagated epidemic, right? And then place, location. Is there a particular place where this disease is associated, like around the Broad Street pump, right? A particular water or food source, okay? So some more examples of information collected. So here's a timing graph, right? Month of the year. So we're seeing, if we have specimens, when do we find the virus or when do we see the antigens? Right, and here's a pattern. Again, this looks like a winter disease, right? Or we can look at month of the year. Here's another timing one, and we can see January, there's a year, right? Oh, E. coli 0157. Whoa, that seems to be a summer disease. Salmonella too, Campylobacter. These are all diarrheal pathogens, right? So maybe people are barbecuing and they're exposing themselves to undercooked food. So all of that was descriptive. In an analytical analysis, we're going to take our data and we're going to compare groups and try and figure out what are the risk factors for the disease, right? So we can compare people that have the disease, people without the disease, and say what is different, right? So when Semmelweis looked at the people, the women who were giving birth, and what was different between those two groups, he was analyzing that data. He was taking his pattern and he was analyzing it, trying to figure out what was the source, right? Analytical studies can be cross-sectional. We just take a population at one given time and we say who's sick, who's not, right? There could be retrospective, where we look backwards and we say, well, who had it, right? If you have an outbreak and you start calling people and saying, where did you eat, right? Where did you go? We're doing retrospective. We're trying to look back at what they did prior to the outbreak and figure out what was correlated with the disease. Or you can do a prospective study, and these can give a lot of information. This is when you take a group of people and you follow them into the future. And there's, I know, a pretty famous prospective study done on nurses, like groups of nurses, following them throughout their lives, collecting information on what kinds of diseases that group got, right? So that would be a prospective study. And so here's a prospective study assessing the risk of type 2 diabetes in Finland, and they looked at a couple of different things. So here's the relative risk, right? And so here they looked at activity and BMI. So if you were inactive and had a high BMI, you're over here. If you're active and you have a low BMI, you're over here. And they also looked at coffee intake. So low coffee intake over here, high coffee intake over here. So who's at most risk for developing type 2 diabetes? People who are inactive and have a high BMI and they don't drink enough coffee. I'm sorry, I'm not laughing about diabetes. I'm laughing at, this is good news for all you coffee drinkers, right? Whereas if you drink more coffee and you're active and you have a low BMI, you're at least risk for developing diabetes, and then there's everything in between. But this data was gathered by taking a population of people, tracking their behavior and their BMI over time, following them into the future and seeing who developed type 2 diabetes as time went on. All right, that's how they gathered this data, or these data. Then there's experimental analysis of data. This is most often what you have when you have a clinical trial, when you attempt an intervention and then you say, okay, does my intervention work? And you compare people who've experienced the intervention with people who haven't. So you have a control group and an experimental group. So this could be a drug trial, right? So here is looking at the use of statins to try and prevent stroke. So we see the prevent of strokes, and we see if it was a fatal, a severe, moderate, or a mild stroke, comparing groups of people that received the statin versus groups that received the placebo. And so we can say, did it seem to have an effect? Does not seem to have much of an effect. It seems that you could have increased chances slightly of severe strokes, maybe slightly decreased of mild strokes. But this would be an example of an experimental study, right? And you all know this, I'm sure. A placebo is a pretend drug. Okay. When you conduct an experimental study, the best way to do it is double blind. So that is when the people doing the study and the people participating as subjects in the study, neither group knows who's actually getting the intervention, maybe the drug, and who is not, who's getting maybe the placebo. You don't want the people that are doing the study to skew the data in favor, and you can even have the effect of people in the study. If they think they're getting the drug, they may report that they feel better. They may have a perception that they're doing better. So usually it's all coded with numbers, and nobody knows who's who until the end of the study. And that's double blind, right? Last thing I want to talk about in terms of epidemiology is a special case of infections called nosocomial infections. Nosocomial is the old word. Most often now they're called hospital-acquired infections. I suspect you've heard of these. This is when you go into the hospital for something, and while you're there you acquire an infection of something else while you're there. So, and estimates are 5 to 15% of patients. You very commonly, nosocomial infections are urinary tract, also respiratory tract and surgical site, right? And if you think about what happens in a hospital, this probably makes sense. What happens to patients that puts them at high risk for urinary tract infections? Catheters, right? What happens that puts them at high risk for respiratory tract infections? Intubation, right? Surgical sites, you cut through the skin or the mucous membranes, you cut through a major defense of the body. So if we say, well, why are there so many? What's going on in hospitals, right? Well, hospitals have this triple threat, right? First of all, hospitals are full of sick people. So you got plenty of microbes in a hospital environment. Also, people who are sick are compromised. Their immunity is lower. Or maybe they're having those procedures, those invasive procedures, catheters and intubations and surgeries that break through their barriers and compromise their ability to defend themselves. Plus, you have a chain of transmission. You have healthcare workers going from person to person to person. And so when you bring these three things together, that is the trifecta. You are increasing the possibility of infections happening, right? So we have lots of reservoirs, we have patients, we have staff, people come to work sick, you can have carriers. There's the environment too, Pseudomonas in the sinks or things like that, where you have hospital environments that can support the growth of some organisms. And then transmission, lots of person-to-person contact. You also have people sharing and breathing the same air. So if somebody's sick and they're coughing, other people in their room could be breathing that air. And then, as I said, compromised hosts, invasive medical procedures, you can have burn victims, you can have people who are immunocompromised. So there's your trifecta. So what do we do, right? So we look back at this thing and we think, well, we have to interfere with these things. How do we interfere with these things? Well, in the hospital environment, we try to lower the number of microbes by sterilizing, disinfecting, right? If somebody has a particularly dangerous pathogen, if they have MRSA or something multi-drug resistant tuberculosis, they're going to be in a separate room. They're going to be in a negative air room so that even the air from their room can't get out and circulate in the hospital. So if dangerous microbes, we're going to try and pull away from the rest of the population. Chain of transmission. Okay, hand washing, right? Semmelweis. Remember Dr. Semmelweis, wash your hands with soap and water. And many studies of hospitals have found that healthcare workers are under such time pressure that they don't stop to wash their hands as often as they should, as often as good practice recommends. And so we see the introduction of more gel stations in hospitals, so that if somebody doesn't stop to wash with soap and water, they can at least gel before handling something or touching a patient. And it's more likely that they'll gel because that's something you can do as you walk, and that has lowered the rates of nosocomial infections, right? Compromised hosts. If you have somebody who's severely immunocompromised, you can move them into a special room too and pull them away from the general hospital population. So once you understand how these things are spread, you can take action to try and lower them. And so standard precautions of hand washing and gloves and eye protection and mask, all of these things can help with the person-to-person transmission. Proper cleaning and disposal of equipment, that helps lower the microbial load, as does environmental control, proper containment of soiled linens. This all prevents the spread, right? And then isolation of patients, either because they have a dangerous bug or they are particularly susceptible. And hospitals are making pushes on all these areas to try and lower those hospital-acquired infections. Okay, that's it for now.